Hi everyone, we'll just give people a couple of minutes to sort of join and then we'll get started in a couple of minutes. Hi everyone, we'll just give another few minutes for people to join and then we'll get started and I'll explain how the session is going to run if you've not been before and we'll get things going. Okay, we'll make a start and people can keep joining as they're coming. So hi everyone, welcome to this Thursday 15 session on psychiatry. My name's Sophie, I'm one of the F1s at Stepping Hill Hospital in Manchester. For those of you who haven't been to one of our sessions before, I'll explain how this is going to run, explain how you can ask questions throughout, and go through sort of some key concepts as well. So today's session is on psychiatry. So just a bit of a sort of trigger warning before we start. We will be talking about sort of topics surrounding mental health and things. If this is difficult for anyone at any point or anything, please do feel free to leave and just message us if you haven't had the feedback link for the slides, if anything sort of comes too much. And so how our sessions run is we'll do a 15-minute exam style with 15 MCQs, a minute an MCQ, which is quite representative of what your exams will be like. Then afterwards, we'll go through each question, the answers, explanations, and then some sort of key topics in psych that are maybe a bit more tricky or that sort of are common exam themes. If you use the Q&A box to ask any questions, and Alex, one of our other committee members, is kindly going to answer them throughout to hopefully not keep you guys too long, because I know it's a Thursday night and very impressive that you're here at 7 p.m. So I'm just going to start with the 15-minute MCQs. I'll time you and tell you when we're moving to the next questions, and then we'll go through the answers. And when we go through the answers, I'll put a poll up so you can all vote. So we'll get started with question 1. And now question 2. Question 3. And question 4. And question 5. And question 6. Question 7, you're about half. And question 8. Question 9. And question 10. And question 11, you're nearly there. Question 12. Question 13. And question 14. And final question, question 15. Okay, and that's your time up. That's the end of the MCQ exam style part. So we'll go through the answers now and some explanations on some key bits of psych. So I'm going to load a poll up, and if you guys can just vote in the poll for question 1. A 23-year-old student is brought into, sorry, I can't read it because of the poll, into the emergency department after behaviour was flagged by their flatmates to the sub-warden. He appeared unsettled and distressed and was repeating the phrase on the phone, "I climbed a tree, I scraped my knee, I cannot see, I will not flee." There's no past medical history of note, but his flatmates note he's been using a lot of recreational drugs. Has a past medical history of family history of schizophrenia. Which of the following thought disorders is this an example of? A, night's move thinking, B, clang associations, C, word salad, D, flight of ideas, or E, tangentiality, which is spelt wrong, so sorry about that, tangentiality. Okay, so it looks like about everybody has voted, so I'll end the poll there and share the results with you guys. And the correct answer was B, so a lot of you got that correct. Don't worry if you didn't, it's quite confusing to get your head around when you first start learning all of the different types of thought disorders. So we'll just go through those now. So clang associations is where the sentence only really relates through rhyming or similar sounds, so that those sentences weren't actually linked or making a coherent linked sentence, but there was the rhyming element. Night's move thinking, which is one of the other options, is a type of loosening of association, which is where you take a logical steps from one idea to the next. So not necessarily by a rhyming tangent, but just you might end a sentence with one word, start the next sentence with it, but the sentences are completely unrelated. This is quite a common feature in schizophrenia when people are psychotic. Word salad is just incoherent speech. It's real words, opposite to neologisms, which is bottom on the table, where it's just made up words, combining words. In word salad, it is real words, but it's in a sentence it's completely jumbled together with very little basis. Flight of ideas is, as sort of the name suggests, if you try and think of these as to, it depends how your brain works, but how you can associate them. With night move thinking, you can think of it as the night moving across the chessboard, which is why that's it's called that. So you're sort of moving from one point to the next without a real link. And flight of ideas is similar. It's kind of jumping from one topic to the next, and this is often in mania and things like bipolar disorder where you're manic. I can just see a question in the Q&A saying the chat's disabled. If you put any questions into the Q&A where you've just put that, we'll be able to answer them there if that's okay. Tangentiality is going off topic without returning to it. We can all be guilty of that sometimes, but this is when it's in a sort of extreme presentation. And not going to even attempt. Echolalia is just repeating yourself, repeating words or questions, being asked a question several times. Okay, so question 2, I'll launch the poll for that one. And if you could all vote, it's not letting me launch this one. Sorry, everyone. There we go. And if you could all vote, a 36-year-old army veteran who presents his GP with repetitive nightmares and flashbacks after a serious limb injury led him to retire 6 months ago. He's otherwise fit and well, apart from a recent compartment syndrome, which is now almost fully recovered from with physio. He describes a complete inability to calm himself down when the flashbacks due to his injury occur, which has led to episodes of panic attack. Given the likely diagnosis, what is the appropriate management? Is it A, refer for trauma CBT, B, refer for eye movement desensitization reprocessing, C, a TCA for the phantom limb, D, prescribe an SSRI, or E, prescribe sedatives and lorazepam? So I think that looks like any last few votes, get them in now. Looks like we've got quite an even split there between A and B. So the correct answer was actually B, and I will explain to you why on the next slide. So this man, which I think a lot of you will have gauged from the question, is experiencing post-traumatic stress disorder. Part of the criteria for diagnosis of this is that the symptoms have to be present for over a month. This is in contrast to acute stress disorder, which I'll go through on the next slide. It can occur at any age and has a variety of symptoms, such as we're experiencing things in flashbacks, nightmares, etc., avoidance of association with the event, emotional numbing and detachment, depression, alcohol and drug misuse, anger, and sometimes unexplained physical symptoms. Gastro symptoms are quite common. So the reason that you would choose eye movement desensitization and reprocessing in this one is because this is quite a severe oh, sorry, it's gone backwards. PTSD, it's been ongoing for quite a while, whereas trauma-focused CBT is more used in acute stress disorder. It is still a treatment, but it said in the question most likely. That's what you've got to be a little bit careful with MCQs, where they can trip you up a little bit. It'll often say things like first line investigation. So a lot of the investigations may be appropriate to do, but it's what you do first. So for this gentleman, we'd be looking to do the eye movement desensitization and reprocessing. Medication generally isn't used routinely, especially where someone hasn't had any kind of therapeutic impact for the for their PTSD. But if it is required, you could use an SSRI, such as sertraline or venlafaxine. Risperidone's used in very severe cases, but this would be really quite a bit further down the line. So by comparison, acute stress disorder, which is sort of what we kind of differentiate between, is the acute stress response in the first 4 weeks after sort of a traumatic event. The symptoms are very similar to PTSD, so they're quite sort of easily interchangeable, except the duration and sort of severity. Things like flashbacks, dissociation, negative mood, avoidance. If this chap had been 4 weeks after his injury, we would have had trauma CBT as first line. You can also give benzodiazepines for this, but this is often just sort of acute symptoms. So there's a question on zopiclone and lorazepam later. You can give it for agitation and sleep disturbance, but you only do this short term because you want to sort of avoid dependence, and it's not kind of dealing with the problem of the acute stress. It's kind of putting a plaster over it, if that makes sense, and tackling a different part of it. So question 3, I'll launch the poll for this one, is a 35-year-old patient presents to their GP with increased cramping and abdominal pain and vomiting. No organic cause for their symptoms can be found through investigations. The GP notices that the patient was on the medication record that they were being treated for low mood. When asked about the prescription, the patient states that they stopped taking the medication about 2 weeks ago as they felt that their depression had drastically improved and they were able to feel enjoyment again in their life. Which of these medications, again, a question wording, is most responsible for their symptoms? I'll give everyone a couple of seconds because it looks like people are still voting. And we'll end that poll there and I'll share you guys the results. So it looks like most people went for C, which is actually the incorrect answer, and I will explain why on the next slide. It's actually paroxetine in this case, but I'll show you why on the next slide. So I'm not going to kind of go through depression too much, because I know this is probably something that everyone's sort of quite familiar with, but the 3 core symptoms to kind of remember from the ICD criteria is low mood, loss of interest or pleasure, and fatigue and low energy. And then you've got all of your other symptoms, such as disturbed sleep, poor concentration, low self-esteem, suicidal thoughts, agitation, slowing of movement, guilt or blame. So SSRIs, and the reason that the correct answer was paroxetine rather than fluoxetine in this case. SSRIs are first line medication in depression generally. It shows you a little bit about how it works on this picture. I wouldn't worry too much about this, particularly as you've done your prescribing safety exam and things. But it kind of blocks the uptake of serotonin, so you've got more serotonin, which leads to better mood. This patient was experiencing discontinuation symptoms from stopping their SSRI after abruptly and not having any tapering down of the doses. There's a question about that later, so we'll go through more about tapering down SSRI doses then, but it's something that you have to gradually reduce over about 4 weeks rather than suddenly stop. In fluoxetine, this isn't actually needed. You don't have to gradually reduce over 4 weeks. It can just be stopped, and it doesn't have the same discontinuation symptoms. Whereas on the flip side, paroxetine actually has the highest incidence of discontinuation syndromes. So while both of these are an SSRI, it's one of those questions that is quite sort of specific with its wording, and probably one of those higher grade questions. SSRIs are something that you should use with caution in children and adolescents because of the increased motivation that it gives you in the first couple of weeks, which can actually increase suicidal ideation and intention, which is why in younger patients you review them quicker than you do in older patients. You review them after a week to make sure that they're not being affected by this increased suicidal ideation. So question 4, I'll launch the poll again. An 18-year-old is diagnosed with schizophrenia after experiencing severe hallucinations and delusions. Which of the following factors in his history indicates the potential for a better prognosis of long-term schizophrenia control? Give you a couple of seconds to vote there. Either A, a lack of obvious precipitant, B, strong family history, C, sudden onset of the symptoms, D, low IQ, and E, social withdrawal and isolation. Looks like most of you are just about answering. I'll give you one more second. A few votes still trickling in. Lovely. So most of you got that correct with C, that it's a sudden onset of the symptoms. So schizophrenia, again, is one of the sort of main psychiatric disorders that's quite sort of complex. It's a chronic disorder affecting your behaviour and your thought processes. The first rank symptoms, there is other symptoms, but sort of the first rank ones are auditory hallucinations, which are generally in the third person, which can help you differentiate from psychotic depression, where in psychotic depression, it's often second person. So it's you're worthless, that kind of thing, whereas in third person, as in schizophrenia and psychosis, it's more thinking people are talking about you and hearing that. Thought disorders, including thought insertion, thought withdrawal, and thought broadcasting, such as your thoughts being available on sort of the television as you're watching it. Passivity, so thinking that you're being controlled by an external influence, and delusional perceptions is the final one. So some prognostic, they're often split into positive and negative symptoms. So the positive symptoms are those kind of acute psychotic symptoms, such as the delusions, the hallucinations. But negative symptoms can be things like reduced speech and flattened affect, lack of initiative. Some poor prognostic factors are a strong family history, which is often a poor prognostic factor in a lot of both physical and mental health conditions. As the question, the right answer was sudden onset. It's actually a positive prognostic factor. That's more likely to be an acute psychosis than sort of a chronic schizophrenia. Whereas if it's more gradually onset, it's more likely to be schizophrenia. Low IQ, a prodromal phase where they social isolate, can often be indicative that someone might be schizophrenic or psychotic, and a lack of obvious precipitant, where sort of on the flip side of that, the positive prognostic factors are things like education, sudden onset. If a stressful life event has precipitated it, it's less likely to be chronic, and no family history. So question 5, just load the poll again. So a 16-year-old female has been admitted to the gastrointestinal ward requiring an NG feed due to anorexia nervosa relapse. BMI is less than 15. Given the severity of this patient's anorexia, which of the following would you not expect to find on her investigation levels? A low BM of 2.5, low estrogen, testosterone, LH and FSH, a high potassium, ECG showing bradycardia, UAs and prolonged QTC, and a temperature of less than 35.5, so a little bit hypothermic. I'll give you just a moment to vote there. I'd say about half. This was always a topic I found quite difficult because the electrolyte abnormalities were always quite specific, so it's something that we can go through on the next slide. So that looks like most of you voted, and a large majority of you have got that right. It's potassium 5.8. You'd actually expect a low potassium in anorexia. So it's diagnosed based on the DSM-5 criteria. It did previously used to be diagnosed just based on BMI, but they've kind of widened that now, and particularly sort of a lot of wider definitions for anorexia nervosa and bulimia nervosa, because there's a lot more complexity to it to just your BMI, and you could have a high BMI but still be struggling with anorexia. So the criteria has kind of changed a little bit towards that. So things like restriction of energy intake, intense fear of weight gain, and often is accompanied by a low BMI. So the investigation imbalances, you get things like your body's slowing down, you haven't got as much energy, you're not getting as many calories. So it's things sort of everything's kind of slowing. So bradycardia, hypotension, and a lower temperature. You also often get hypokalemia rather than hyper. Again, everything lowering, your electrolytes are imbalanced. Often you'll do refeeding bloods on people in hospital if they're being NG fed, and that's to monitor the electrolyte imbalances. Your sort of hormones, estrogens, testosterones and things are lower as well. Often anorexia, you get stunted hormonal phases. So you often, if you're a girl, will get your periods will be stunted, or your periods might stop during a sort of relapse of anorexia because of these hormone imbalances, because you're not getting sort of enough calories and nutrients. You can also get raised cortisol and growth hormone. The growth hormone's trying to counterbalance that, and an impaired glucose tolerance. So it's often hypoglycemia, so it is often low because you don't have enough sugar in the body, but you can get high glucose just because your control is completely imbalanced. And so now we'll go to question 6. Sorry, I don't know if I shared the result for that. So if you can all vote for question 6, we've got a 54-year-old female presents to her GP with her husband, who's worried his wife is struggling to manage her OCD. He noticed that she's become increasingly concerned about burglary in the past 3 months, with no clear explanation or change in safety triggering this. She's checking and rechecking the door is locked at night, and only feels able to settle when she's locked and unlocked the door 3 times and rubbed on the door handle. His wife accepts that she's not coping at present and would like some help managing her symptoms. So which is the first line treatment for these symptoms, given that they're occurring only at night? So CBT and response prevention, sertraline, clomipramine, psych assessment in hospital, or DBT? Just give you a moment to vote there. I'll just give you one more minute because a couple of people still seem to be voting. I'll also just, oh, sorry, I've sent it to, I'll just pop the feedback link in if I do run over 8 and anyone does have to leave.
Sophie, sorry, in the chat there's a few questions just about why potassium's low in anorexia. Would you mind just going through it again?
Yeah, sure. I'll go back a slide. So the potassium's low in anorexia because it's the way your sort of body, how can I explain this? It's the way your body's processing that refeeding. So where you're not getting enough calories, the body's trying to sort of use its stores to feed it. It's similar to why we do refeeding bloods in patients who are NG fed. Hyperkalemia is quite common in sort of poor dietary intake generally, because you've got a loss of the kind of to the GI tract, you've got the loss of potassium, and the kidneys aren't functioning as well. Does that kind of make sense? Not sure. So ask in the chat if it doesn't. You can often get like things like metabolic alkalosis and things as well in anorexia because of this, because the electrolytes are imbalanced. If that doesn't make sense, someone tell me and I'll try and explain it better. So I've gone to that slide, but the correct answer for that is, as most of you said, CBT and response prevention. So this was another one where the wording of the question was really important. So OCD is characterized by the obsessions and the compulsions, which do have slightly different kind of meanings. The obsessions are those unwanted, intrusive thoughts and worries, whereas the compulsions are repetitive behaviors that the patient feels like they need to perform, and they get some relief from performing those compulsions for the obsession. Risk factors for this, again, family history is always massive. Age quite young, it's often onset quite young. Pregnancy and postnatally, and history of neglect and abuse. So the management for this is quite mild, which is why the question kind of emphasised that she's only experiencing these symptoms at night. So you'd want to start, as you do with most psych conditions, you start with the sort of least invasive and most kind of talking therapies kind of options before you step up. So you'd want to start with CBT, which can include exposure and response prevention. One of the options, I think DE was DBT, which is predominantly used in personality disorders rather than OCD. But you can use fluoxetine in OCD. And I think I saw a question in the chat earlier that was about fluoxetine often being used in adolescents. That is true. Adolescents and children, when they're being treated with SSRIs, is often fluoxetine. So just a little quick note on what exposure response prevention therapy actually is. It involves taking a patient. It's quite a brutal kind of type of therapy, but it involves exposing them to the anxiety provoking situation, and then stopping them from engaging in that compulsion, which gives them the relief. So it aims to target anxiety, and by breaking that habit, you lose the compulsive response. So if we look at that cycle, you're trying to kind of stop her into that cycle. And question 7, one with a little bit less reading, which is nice. You can all vote in this one. Which of the following is not a first-rank symptom of schizophrenia? Now, we have been through this earlier, so I'm not going to re-go through schizophrenia, but see if you all remember. Okay, so it looks like everybody was either listening earlier or already knew their first-rank symptoms. So yeah, blunting of affect isn't a first-rank symptom of schizophrenia. It can be one of those negative symptoms that we talked about from the positive and the negative side, but it's not one of the first-rank symptoms as the others are. Blunting of affect is the correct answer there. Well done, everyone. And we'll go to question 8, which is a question type that I would have always hated. This kind of question, because lithium is very confusing. But a 46-year-old patient is started on lithium after being diagnosed with bipolar disorder following an episode of mania, which led to hospitalization. When should the lithium levels be monitored? So taken 12 hours after dose, monitored weekly, 12 immediately after dose, monitored every 3 months, 6 hours after dose, including TFTs and UNAs every 3 months. Only monitor if there's signs of toxicity, or lithium levels and TFTs and UNAs must be monitored every 6 months. I'll just give you all a minute for that one. It's a very wordy question to read, this one. So you'd maybe want to, in your exam, feel free to not stick to the 1 minute a question and use for more complicated ones. Okay, so it looks like most people have voted there. And the correct answer is what the majority of you have gone for. It's you take it 12 hours after dose and then monitor weekly after initiating. I've got a slide on kind of the breakdown of lithium monitoring that I'll come to in a minute to explain that. But firstly, just to quickly go through bipolar disorder, again, probably something that you're all quite familiar with, but it's characterized by these periods of mania or hypomania and periods of depression. It can often go masked as depression for quite a long time. So people will often be on an SSRI or on an antidepressant because it's been thought that they've had depression and then can have a manic episode, and we realise that that's actually not been fully stabilizing the mood, although as it says later down the slide, you can still just monitor and manage the depression side of bipolar with things like SSRIs and talking therapy. Just a little highlight on the difference between mania and hypomania. Manias, they present very similarly with the abnormally elevated mood, irritability, sort of generally irrationality and risk-taking behavior. So you'll often hear that kind of stereotype of spending a lot of money, gambling, drastic changes to appearance, that kind of thing that maybe they might give you like a mental state exam for in the OSCE and that kind of thing. Whereas hypomania, you don't have the psychotic symptoms. So you have all of the symptoms with the sort of mania and elevated mood, but you don't have that kind of psychosis. So the management is generally lithium still, even though it is a very complicated one to dose and to monitor, it is still first line, but sodium valproate can be used as an alternative. So I'll just go through the lithium monitoring now. You all did really well, so maybe it's just something I found a bit more difficult at uni. So you always take the sample 12 hours after dose. Really important to monitor your lithium levels. It's something that actually I've been escalated a couple of times on call recently, is when lithium levels are off. So after you initially start treatment, as this patient had, it's weekly monitoring. And then you also monitor after each dose change until the concentrations are stable. So if you're finding that the lithium's still out of range, it might actually mean that you're monitoring more than weekly, but in general, you aim to monitor weekly. So that's like this patient in the question. Once the patient's established on lithium treatment, you can just monitor every 3 months. But after changing dose, again, it's weekly until the levels are stable. TFTs and renal function, you do want to check every 6 months. But that's not kind of part of the like regular lithium monitoring. So I'll stop sharing that poll. And question 9, we're nearly there. Well, we're partway there. So we've got an FY1 working in ED. A 58-year-old patient attends for the 3rd time in the past 6 months with symptoms of chest pain and palpitations. There's no cardiac or organic cause identified, with normal sinus rhythm on ECG, negative trop and negative D-dimer. So we've kind of excluded all organic causes. Which of the following could explain this patient's symptoms? The A, hypochondrial disorder, B, conversion disorder, C, Munchausen's disorder, D, malingering, or E, somatization disorder. I'll just give you a moment for that. And it looks like most people have voted there. And most people got that question correct. So these are all kind of unexplained symptoms. We can't find a physical cause, that kind of strand. There is differentiations between them that you can kind of help you remember the difference. So hypochondrial disorder, it's common to kind of sort of facetiously brand people a hypochondriac, but it is commonly a fear of undiagnosed cancer or another serious illness. So this is something that you can kind of use to remember what if there's hypochondria in the question, it'll often be about sort of cancer with lots of negative investigations. Conversion disorder is an interesting one because it does actually manifest as sort of physical symptoms. So you can often get a sensory or motor loss, such as loss of nerve functioning. Munchausen's involves producing physical symptoms with no organic cause. So this can be things like producing chest pain without a cause, but in this case it was sort of more somatization because it was the physical symptoms. So it's kind of when people will say they have symptoms that perhaps aren't present. You be very careful when you are dealing with these kind of patients though, because you want to deal with them very sensitively and empathetically, and you don't want to just brush it off as just not being sort of a valid, because there's clearly something going on that's bringing them sort of into hospital or into doctors, because I certainly wouldn't want to be spending my time there. So yeah, just be very sensitive with these patients. Malingering involves sort of exaggerating of symptoms for personal gain. So an example I always kind of have in the back of my head is if you're making whiplash claims. Obviously, a lot of people will perhaps try and make whiplash claims who aren't malingering, but just as a way to remember it. And then somatization is when people do have physical symptoms, but it's unexplained by multiple negative investigations. So question 10, I'll launch the poll up. So this is, which of the following medications is the most likely to cause the side effect of tardive dyskinesia? A, mirtazapine, B, paroxetine, C, haloperidol, D, diazepam, or E, clozapine. Give you all a minute again. Okay, it looks like most people have voted there, and I'm conscious that it's getting closer to 8, so I'll share this one. So the correct answer here, again, a lot of you were right, and it is haloperidol in this case. So this is a really good table that I have taken from PassMed, that gives you a really nice breakdown of antipsychotics. You've got your typical and your atypical antipsychotics. So your typical antipsychotics are your things like haloperidol and chlorpromazine, which is what we had in the question, where those extrapyramidal side effects and sort of Parkinsonism side effects are quite common. You can get them in both, but it's just more common in the typical antipsychotics. So often if people are struggling with things like the dyskinesia and the akathisia, you might think about switching them to an atypical. They all act on dopamine receptors, but they do act in slightly different ways. As I said, the extrapyramidal side effects are more common, which is why in this case haloperidol was the correct answer. So you get things like acute dystonia, things like muscle contractions, severe restlessness, and tardive dyskinesia, which is the kind of movements, the involuntary movements such as chewing of lips, smacking of jaw, that kind of thing. So that's a really good table that I would recommend just like sticking somewhere if that's how you learn. Question 11 is, a 17-year-old male has been reviewed by his GP 6 months of low mood, loss of energy, and poor concentration. He's becoming disheartened as his symptoms have continued to get worse despite engaging in CBT. The GP feels that a trial of sertraline is reasonable given the length of his symptoms. Given his age, when should an antidepressant review be booked in? And I did actually give this away earlier in the talk, so sorry. I'll give you a moment to again vote for that. Looks like people are voting quite quickly for this one, so I'll end the poll there and share the results. Yeah, so this is 1 week. This is because of his age and, as we mentioned, that increased risk of suicide because of the increased motivation. So 2 weeks is incorrect in this case, but that is generally the follow-up time after commencing CBT. So to see how people are doing with the talking therapies. We often, apart from in under 25s where we're worried about that increased suicide risk, it does actually take a little bit of time for SSRIs to start their effect. So 4 weeks is generally quite a reasonable amount of time to review people after, if they're not under 25 with this increased kind of risk, or if there's any other problems that mean that review would be needed earlier. 3 months is too long. That's the amount of time for lithium being monitored, and SSRIs, you want to be checking in before that as to whether the mood's improved. SSRIs also don't need routine blood test monitoring. There is some SSRIs such as citalopram can affect QTC and things, but there's not a routine monitoring in the same way that lithium is very protocolized. You don't want to be not routinely following up any patients really. So that's the incorrect answer. Question 12 is an 86-year-old is reviewed in hospital for admission due to CAP. The daughter has expressed concern that her mum's memory seems to be worsening, and she wonders whether she might be getting an onset of dementia. Which of the following symptoms would be more suggestive that this patient is suffering from dementia than depression? So, sudden onset of symptoms such as poor memory, short-term memory loss, an AMTS score of 9 out of 10, physical symptoms such as sleep disturbance or loss of motivation. So again, if everyone can vote in the chat there. And again, it looks like most people have voted. So a lot of you got that right, that this would be more indicative of it being dementia is short-term memory loss. So just a bit of the difference between depression and dementia. It's a very common, it's very commonly missed in the elderly depression. I think it's generally thought that it would have been onset in earlier life, but actually it's really quite common in the elderly population. And I've just finished a geriatric job, and we get a lot of patients who actually come in with things like overdose, which is very sad. So factors that suggest depression over dementia, things like short history and rapid onset, rather than dementia, you're looking at a longer term cognitive sort of decline and functioning. Biological symptoms like weight loss, sleep disturbance, poor memory is often global in depression, whereas dementia starts as poor short-term memory. So you start sort of forgetting recent things and then it gets sort of longer, whereas in depression, it's just generally poor memory globally. And in depression, there's less abnormalities in those kind of scoring tests. So an AMTS score of 9 out of 10 is pretty impressive for someone with dementia, although there can be fluctuating cognition. So it's important to sort of remember that dementia can fluctuate a lot, and you might be able to catch your patients in a bit of a lucid period. So this question is going to be absolutely everywhere when you all start F1, which you've all got your deaneries now, haven't you? So congrats on that. You're on FY1 on call, holding the medical bleep overnight. You're asked to review a patient who was having difficulty sleeping during hospital admission. She's 90 due to the commotion on the ward. The patient is admitted with multifactorial falls secondary to progression of dementia and increasing frailty. The medication chart contains a lot of polypharmacy due to multiple comorbidities, but you know she's also on PRN, lorazepam for agitation. Which factor from the history would be the main reason to avoid prescribing zopiclone in this patient? Age, no plan from the day team about zopiclone, history of falls, polypharmacy, or there aren't actually any contraindications and this patient could have zopiclone. So I'll give you a couple of minutes. And it looks like the poll might have stagnated a little bit there. So I'll share those results now. So the main contraindication here is the history of falls, which I'll go on to describe in the next slide. But to be honest, I think you could justify any of them when you're on call as a reason to really think about whether you want to be prescribing zopiclone. So zopiclone is a bit of an on-call nightmare task. Patients will often ask for it. It's got a reputation of being addictive, which it is, but often the patients asking for it, one, don't really know it's addictive, and two, they're asking for it because they can't sleep rather than because of drug-seeking behaviour, although that is something to be aware of. But there's a lot of adverse effects of zopiclone that you do need to be aware of. It's not to say it shouldn't be prescribed. It definitely has its place and it's very reasonable in some patients. But some contraindications to it are things like in this, the recurrent falls is the main contraindication because because the adverse effects of zopiclone are quite similar to benzodiazepines through increasing the risk of falls, because this patient's already falls risk and they've got a history of falls, if we're going to sedate them further by giving them zopiclone, especially if they're on any kind of anticoagulant, any blood thinners, it's a very good justification to say no to the nurses, and it be very valid, because the nurses are amazing, but sometimes you do have to say no to giving zopiclone if you think it would be a falls risk, because if that patient falls, hits their head and is on a Pixman, has a bleed, it's not going to look great. But other contraindications are things like respiratory depression because of those sedating effects, and neuromuscular weakness, again for that same reason. By sedating you, it can kind of further depress an already depressed respiratory system, which we don't want. Dependency is something to be aware of, but like I say, often that's kind of not really the case. In the elderly, it can be a reason, but that's generally more related to them being a higher falls risk or not wanting to sort of sedate them. Lorazepam and zopiclone, this is extra sedation, but because it was on the PRN part of the drug chart, it might not have actually been given. So that's why it's not the main contraindication in this question, where it was the history of falls. Maybe if they were getting like regular lorazepam, you'd be sort of more thinking, how much are we sedating this little frail 90-year-old woman, and does she need it? Obviously, there is a lot of cases where zopiclone is very appropriate, and where lorazepam is very appropriate. If you ever feel at risk with a patient, if the patient's putting other patients at risk, if they're putting themselves at risk, if they're aggressive to the point of not being able to be talked down, you've got security, all that kind of thing, you spoke to your med reg, there is justification, so you can give it, but just to be aware that you can say no. Question 14, we've only got 2 to go. I'll just launch the poll for this one. So as the foundation doctor, which of the following sections under the Mental Health Act could you put on a patient in the emergency department with severe mania, trying to self-discharge, who doesn't have the capacity to make this decision due to their manic episode? So I'll just give you a moment for that, and then we'll go through all of the different types of sections. Just another second there. And I'm conscious it's 8, so I'll try and keep this speedy. Okay, so again, a lot of you were right, but I can see where some of you were maybe thinking it might be A section 2, but the answer is actually D, section 5.2. So the different kind of sections that hopefully you won't need, but if you do, you can section people under the Mental Health Act if you feel they're a risk to themselves by discharging, or if kind of they're in an acute manic episode, etc. So section 2 is when you can admit someone for assessment for up to 28 days. You can't then renew this section after the 28 days. You'd have to get a new section, but an approved mental health professional makes the application, and 2 doctors have to have recommended it, so you can't ever make the decision on your own, which I think is quite nice, that you can't sort of be solely responsible for sectioning. So 1 doctor has to be approved, so you have to kind of be like a psychiatric doctor or something, and in this, treatment can be given under a patient's wish, without a patient's wishes. So that's the section 2. It's a bit of a longer term. If you were sort of a junior in the emergency department, it wouldn't be the you wouldn't be the sort of section that you would go for, but is a good section when you've got 2 doctors, etc. A section 3 is admission for up to 6 months. So this is like a quite a long section. So this is probably going to be quite an unwell patient, a patient with quite complex issues. Again, it needs 2 doctors, and they must have seen the patient in the past 24 hours. So often it can actually be quite difficult to get a section 3, particularly during COVID. There's a lot of problems with that because people weren't necessarily seeing multiple doctors. The reason that this one is sort of, this criteria is more strict, and because it's longer, again, you can give treatment against the patient's wishes. So all of the shorter sections that kind of you'll probably be involved in as a junior, they're until someone more senior or until a specialist psychiatrist can come and assess them. A section 4 is for 72-hour assessment. This is used in an emergency, and then it's often changed to a section 2. Whereas a section 5.2 is sort of doctor's power, they call it, as opposed to a section 5.4, which is effectively the same thing, but is the nurse's power. The nurses can detain for longer, generally because we do have some psychiatric training in kind of medical school and things, whereas the nurses, if you're an adult nurse or a peds nurse, not a mental health nurse, you won't have had as much psychiatric training. So section 5.2 can voluntarily hold a patient in hospital and legally detain them for up to 72 hours, whereas the nurse's power, the 5.4, a nurse can detain a patient for up to 6 hours. So the nurse would likely detain them, get a doctor to come, you'd detain them for 72 hours, and then you'd get someone more senior if it was still needed. So the difference.
Sophie, just before you go on to the next sections, there's a few questions about which sections you can use in A&E. It's not something I'm particularly familiar with. Do you know which ones you can use in the emergency department?
I know that this is something that I wouldn't like to give you false information on, but I know that you generally can't, definitely can't put in a section 2 or a section 3 because they have to be in kind of an acute. I think you could put in a section 4, definitely, because that's in an emergency situation. You could put in a 5.2 as well, I think, but maybe double check that.
I'll have a little Google and I'll put the answer in the chat.
The main difference, I can see a few people asking the main difference between them because they are quite similar. I think the main difference is that the section 4 is maybe more emergency, is my understanding of it. But yeah, we'll let Alex have a Google and get the difference. A section 135 is a court order that you can obtain to allow the police to break into a property to remove a person to a place of safety. Probably not something you're going to experience unless you're on like an acute psychiatric placement. And a section 136 is if a patient's found in a public place by police, they can take them to a place of safety, which is often the hospital, to then be properly assessed. So question 15, final question, and then we'll circle back to that answer if we've not clarified it. So a 36-year-old patient who was admitted to hospital following a fall and head injury is reviewed on the acute medical unit. His CT head is nil acute, so no bleed. Overnight, the patient had a seizure. It's suspected that the seizure is related to alcohol withdrawal, as the patient is a known alcoholic who's been started on chlordiazepoxide or thiamine. How many hours after admission is it likely that the patient would start seizing due to alcohol withdrawal? Is it A, 6 hours, B, 12 hours, C, 24 hours, or D, 36 hours, E, 48 hours? I'll just give you all a minute for that. And we've got a bit of a mix on this one, probably because all of the timings are quite similar. But the correct answer is 36 hours for seizures. I'll go through alcohol withdrawal on this slide. So this kind of explains to you all of those answers that were there and why 36 is the correct answer. So for alcohol withdrawal, it'll generally be about 6 to 12 hours after. So very possibly can be while a patient's in ED, you could very well be waiting that long. Hopefully not, to be prescribed some chlordiazepoxide, etc. So those symptoms start things like tremor, sweating, getting tachycardic, anxiety. These patients will appear quite distressed, sweating. You think, oh, they look like really not great. 36 hours, you can get the seizures onset. And then the longer the withdrawal goes on, the more serious it becomes. So you can get delirium tremens from 48 to 72 hours, which includes things like a tremor, confusion, and where you're getting sort of the more psychotic symptoms like delusions, auditory hallucinations, fever, and tachycardia. If you don't know that this patient's alcohol dependent, it can often present sort of as something that you might think they look sort of septic, that kind of thing. So it's just one to bear in mind. Obviously sepsis is key to rule out though. First line, you'd give a long-acting benzo, such as chlordiazepam oxides, generally used, or diazepam. There'll be a trust protocol wherever you go for F1, but there's like generally a reducing dose. So you'll start them on it and then reducing dose. Also good to, if they're not already, establish them on oral thiamine longer term to prevent Wernicke's and that kind of thing. Carbamazepine can be used for seizure treatment in delirium tremens. It's generally the best anti-epileptic for DT, specifically like the DT specific seizures. Things like valproate and things generally don't work. I'm guessing it's because of the mechanism is the reason for that. So that is the end of the questions. Thank you very much all for coming. Hopefully that was useful. All of our questions are independently quality checked beforehand, so should all give you the right answers. So hopefully that has helped to clarify some myths of psychiatry, some of the complicated things such as lithium. If you can complete I'll put it in the chat again. If you could complete the feedback form either by the QR code or the Google form, it'd be really grateful. When you go to F1, you'll know how you need to get loads of things for your portfolio. And also it means that as a committee, we know what we can do to improve future sessions.
So what I can see about all the sections, section 5.2, you need to be an inpatient. So you can't use it in like A&E or outpatients or the community. I think you can use section 4 to sort of admit them to then do a section 5.2. That's maybe how you do it in A&E.
Perfect. Sorry everyone if that question was a bit unclear. Hopefully that's answered it. I'll just let everyone get the feedback link and then we'll end the Zoom and have a nice evening. Congratulations on all of your deaneries and things. Everyone got the link.
And the haematology questions are coming out as well. There are a couple who asked. Sorry, it's been a slow week. They are coming.
Okay, I'll end it here. I'm guessing everyone's got the link who wants the slides and is being kind enough to give feedback. So thanks for coming everyone. Have a nice evening. I'll end this Zoom.